Okay.
This gentleman is 47 years old, male. He's coming with pain over the medial compartment of his right knee. Um, Perhaps I should show you the. Um, he's an active person, healthy person. Um, he's playing the weekend kind of sports activity, and these are the MRI images as well as the lung X-rays. Um, who would like to start? Who would like to answer the question? Because perhaps we should get the opinion from the audience. So, Rushdie, what do you think?
So in short, I think we have to do root fixation. That's what I do. Root tear fixation plus high tibial osteotomy.
Okay. دكتور محب تفضل.
I will actually do high tibial osteotomy only.
Okay.
Whether to do root or not, the results are usually the same.
Okay. Any different opinion from the panel side?
Dr. Ayman, how is the MEPTA, the medial proximal tibial angle? How much is it? I cannot read it.
Well, he has an extra articular varus, definitely.
Okay. So if it is less than 85, I probably do a high tibial osteotomy, and probably won't do anything for the meniscus.
You want to do anything for the meniscus?
I believe this is some kind of overdoing in my mind.
Would you scope him then?
Yeah, definitely. I do regular scoping before I contemplate on doing any case of arthrosis, just to make sure that lateral compartment is fine.
So perhaps everyone agrees on the concept of correcting his varus, high tibial osteotomy. So Rushdie thinks that root repair would be ترحم بيت تفضل. Okay. شو So there is the concept of saving the meniscus, root repair, if it is repairable, obviously. I mean, every one of us would prepare himself to go and do root repair, but obviously sometimes you might not find it feasible to be achieved intraoperatively. But if you have the chance to repair it, you might have to repair it. We've heard about the kind of displaced medial meniscus and the subluxed meniscus that you have to reduce, and the attachment points in the first day. But Dr. Maher Bey, high tibial osteotomy, would you use bone graft or would you do it without graft?
I always do it without graft, and I was lucky to present a work in the American Academy in 2009, and presented my work on cases of tibial osteotomy up to 14 millimeter without bone graft, and I got a high rate of success.
Okay. Would everyone agree with the concept of not using bone graft? Dr. Ahmed Bey, تفضل. Okay. Exactly.
The smaller angles with intact hinge, there is no problem. Larger angles, they need mechanical support, like we may put the cervical cage or bone graft to add stability to avoid post-operative hinge fracture and loss of fixation and none or delayed.
When you don't use bone graft, when would you allow these patients weight bearing?
Well, actually, it depends on the how sure you are your hinge is intact and good by the positioning of the hinge, uh, protected by the intact superior tibiofibular joint. The fibrous tissue of the capsule makes a good protection, and if the angle of correction is a gap is within 10 millimeters, and the fixation is good, the plate is good and locked screw, I would allow the patient to do touch weight bearing from day one for
Okay.
6 weeks, and then increase the weight bearing over the coming 6 weeks. The next 6 weeks.
دكتور ماهر تحب تقول حاجه؟
Also depends on the weight of the patient. If the patient is obese, we delay always weight bearing, even partial. And it depends on also on the perfect internal fixation. These
Okay.
2 points.
What do you mean by perfect internal fixation?
I mean, in osteoporotic bone, we almost always use locked plate, locked T plate. And if the patient is not obese, we may allow partial weight bearing after 3 weeks. If not, you can use any mean of fixation, locked or non-locked, and there is a lot of studies about this point. It doesn't matter.
Dr. Akram, do you use bone graft for your cases, and what method of fixation?
I follow the paper of
Dr.
Professor.
Akram Hamad.
Oh, sorry.
That is,
According to the amount of correction. If it's a small amount of correction and small wedge, no, just lock the T plate and no graft.
okay. Akram Dawji, would you like to say something?
I follow the policy of Professor Meher Lassel. I know this paper. Up to 14, I don't put, especially if the hinge is stable, because some articles are stating that the hinge gets broken by any means if it is above 7 degrees of correction. So if you put a locked plate and use the technique of golden screw and did some compression laterally, it's stable, not necessarily broken or not.
Okay. Well, I think we'll move on so we can see other cases. I'll just show you what I did for the gentleman. In fact, I used a standard T plate. It is non-locked. These are very cheap type of plates. Standard T plate with bone graft, and this is him 6 months down the line. He has restored the realignment of his knee, and this is the range of movement. You can see him coming back from the gym with his costume, sports costume. So this is another case. This female is 62 years old, and she has medial compartmental osteoarthritis. You see the patellofemoral joint minimal changes on the patellofemoral side, and the erosion is mainly central on the lateral side. Turwel Nassar, what would you like to do with this lady?
Exhausted the conservative measures, the modification of activities, and using walking stick on sanitary assist. This is a straightforward case for me for a total knee replacement.
Total knee?
Yeah.
Okay, fine. Anyone else would opt for something different from total knee?
Yes, Dr. Ayman.
Please.
I look at the age of the knee, not at the age of the patient.
Yes.
So, in this case, I almost always perform a high tibial osteotomy because the lateral side as well as the patellofemoral is perfect. So, high tibial osteotomy in this patient of 62 years is good for him.
Akram Dawoodi was defending the osteotomy and said he wouldn't do it if it is a complete loss of the medial joint space. He was just defending this now.
Actually, in the Egyptian society, if it is lady above 60 and having bone-to-bone one compartment, I believe there would be some changes as well in the lateral compartment. So I would rather scope her first and give her both choices. I might go either way and get the approval of her going either way.
Which ways?
Um, I might do a high table osteotomy if the MEPTA is 85 or less. If it is, by the way, any higher, 84, 85, 86, I won't. I will go for total knee replacement.
We've just heard that it is not the age.
Yes,
It's not a major difference between 62 and 65. She's above 60.
yes, yes. I probably would scope here and not go for osteotomy, most probably.
Okay. Right. Any different opinion? Total knee replacement? Okay.
And we used to say that osteoarthritis is a global disease of the joint.
True.
Usually in a 62
True.
with that amount of arthritis of the medial compartment, you'll find the changes on the lateral compartment and you'll find the changes in the patellofemoral joint.
True.
The success rate of the total knee in this group of patients is very high. So I would give her one operation, total knee replacement.
Dr. Rajdi.
Just a hint about the idea of Dr. Akram to do arthroscopy to assess the lateral compartment. The flattening of the lateral surface in X-rays definitely showed that it is at least grade 3 or grade 4. So no need for arthroscopy. The flattening of the lateral surface denoting that the cartilage were about grade 3 or grade 4. So no need for arthroscopy, I think, for total knee as Dr. Tariq.
I'm not sure really if arthroscopy would be needed to make a full assessment of a joint. Because you have the chance to get standing x-rays in different views, and you see where is the worn side of the joint. You have the chance to get long-standing x-rays to assess a mechanical axis, and you have the chance to perform an MRI if necessary. And in the majority of cases, you don't need an MRI scan to assess whether this patient has arthritis over a certain compartment or not. So I'm not sure really if arthroscopy is necessary to make a full assessment of a joint.
Just I want to ask about the widening in the lateral joint space. It is a standing view. What about if there is ligamentous weakness on the lateral side?
You can clinically
and
assess
this
that.
widening is not a true widening, it is due to ligamentous
Trauma?
deficiency.
It could be, but at the end, you can see if it is correctable or not. You can see. You wanted to comment, Dr. Wyatt, please?
About doing an arthroscopy in the same session before making the final decision to make an arthroplasty, there is a couple of studies emphasizing that there is a considerable increase in the postoperative infection rate if you do arthroscopy in the same session before you do either a uni or a total knee replacement.
Sure.
This is the first thing. Second thing,
Performing arthroscopy in the same session of knee arthroplasty would increase the incidence of PGI.
in this particular case also, I would think about replacing the patella. I know this is
Sure.
another issue, but this patella is very inviting me to do a patella replacement also.
This is the lady who's bone on bone over the medial compartment. This is the lateral compartment. This is the ACL. And this is the immediate postoperative X-ray performed at uni. Let us move to another perhaps debatable case. This is the last case. We have 6 minutes. This is 65. Who would you like to comment? Perhaps I should show you the MRI scan. This is the MRI scan. This is the degree of involvement of the joint. And he's 65. Sorry? 72. Yes. He's around 70.
I think there is multiple factors here in favor of replacement of a total knee. One of them in the MRI is the very poor quality of the subchondral bone, which if we put a uni, I think the possible failure rate of the femoral component is higher than usual.
Sure.
But what in this particular patient, yeah, I would do a total knee, and I would put in question to put a stem or not. This is another issue.
Please, yes.
Yeah, thanks. This 65 years old man, I just
72.
still
I
young.
forgot. I put 62 while in the MRI
Yeah.
it was same
We
72.
didn't talk about the patient symptoms. Is it
He's
pain?
he's
Is
he's, he's
medial?
a healthy 6 feet tall guy of average age. BMI is around 30, 32 perhaps. He's a retired physician, an active person. Has developed pain in his knee over the last
Painful mainly on the medial
5-6
side.
months. That's not responding to medical treatment, recurrent effusion, and he's not happy.
Yeah.
Dr. Adham?
Is the pain mainly on the medial side? We can think about uni compartment.
Uni compartment.
Yeah.
Okay.
After having the finishing the conservative management and the steroid
He
injection.
has been on non-steroidal anti-inflammatory
So
drugs
it's a
for
good case for uni compartment.
5 months.
It's a good case for uni.
Uni? Adham?
شكرا دكتور ايمن على البرزنتيشن الجميله دي. هو العيان ده يعني ستريت فورورد كيس بتاع اوستينوكروزس في الميديال فيمورال كونداي، وفي اللاترال اكس راي انا شايف اللي هو البوستيريور كاتش از بريزيرفد، ده معناه انه عنده فانكشننج اي سي ال. انا محتاج اكزامن الميديال ليجمنت هلاقيه في الغالب فانكشننج، او اعمل ستريس اكس راي في الغالب بقى فانكشننج. ف this is the only indication we do uni while there is no bone on bone articulation. فده very good case for uni.
Uni? Okay. Sorry. Unfortunately, I don't have one. But there wasn't a significant varus on this knee. There wasn't. Okay. It just developed a sunk. Dr. Mohammed. Totally. Okay. Right. Okay. Anyone from the panel would like to comment? 72, sunk, subchondral collapse, effusion for 5 months. Totally. Okay. Dr. Meher agreed on totally this time. Can we go back to the X-ray, please? Can we go back to the screen, please? Okay. Well, in fact, I'll show you the intraoperative video because it shows you subchondral collapse. The cartilage has collapsed and detached from the underlying bone, and it's failure not for the cartilage, but it's failure for the subchondral bone. So there is no support. A very big flap, significant part of the condyle has been affected. It's not a small fragment, as you can see. And as Dr. Adham just said, this is a good indication for uni. This is what is left behind from the medial femoral condyle. So there was enough bone to support a unicompartmental knee arthroplasty. This is the uni performed, and this is the post-operative X-ray, and this is the functional outcome 4 weeks down the line. Please. If I don't have enough support for a uni, I mean, if the bone loss on the medial side is that significant not to support a uni compartment, total knee replacement would be the answer. Yes, I agree.
I'm a bit worried about the bone quality of the medial femoral condyle because in the MRI, the amount of avascular necrosis of the medial femoral condyle is gone beyond the support of the surface support of the uni. So I'm a bit worried about the longevity.
Okay, it is to do with the mechanical function of the medial femoral condyle, and I see that there are exaggerated marrow edema beyond the necrotic area, but it doesn't mean that the bone on the medial femoral condyle has completely failed. Yeah, yes, MRI shows exaggeration of marrow edema into the healthy bone beyond it. It is a reaction for the collapsed fragment, but it doesn't mean that the bone itself is weakened. I don't think you can use bone graft with uni, but perhaps you should do so if you are performing a total knee replacement and you have defect over the medial femoral condyle. Well, I think I would like to thank the panel. I would like to thank the audience for their contribution, and I hope that the session was satisfactory to you to answer the question of when to perform high tibial osteotomy, unicompartment, and total knee arthroplasty. And thank you very much for your attendance.